Hello friends, welcome back to my channel YouTube. Okay, so let's talk about today that disorders of the adrenal gland. So in these cases, basically, I'll go through the basic anatomy and the physiology. After that, subsequently, I'll go through the pathological disorders, and of course, I'll also talk about the diagnosis and the workup and the treatment also over here. Okay, so today's topic is the disorders of the adrenal gland. Disorder of adrenal gland. So it's one of the most important topic regarding endocrinology as far as the medicine is concerned. I'll also try to cover the pediatric cases also over here. Okay. Now, if we say, for example, where is the location of the adrenal gland? So the location of the adrenal gland is superior to the kidneys, as we know. Okay. And if we see the further structures of the adrenal gland, what type of the structures we'll get over here? So for example, I'm drawing the adrenal gland over here. Okay, and on inner structures, for example, over here. Now, within the adrenal gland, we can categorize in the two ways. One is the adrenal cortex, another is adrenal medulla. So within the adrenal cortex, we'll get the three layers. Okay, so for example, if I consider this three layers is the adrenal cortex layer, and the inner layer is the adrenal medulla. Just for understanding purpose, I am saying you guys over here that the first layers of the adrenal cortex, as you know, is the basic anatomy that is known as zona glomerulosa. Okay, the second layer will get over here, zona fasciculata, and the third layer will get over here. There is the nothing but the what? Zona auricularis. And the different layers, they are responsible for the secretion of the different kinds of the hormones. Okay. So for example, if you talk about the zona glomerulosa, they are responsible for the secretion of steroid hormone. What is that? That is the mineralocorticoid, or rather we can say over here the aldosterone. So the zona glomerulosa, they are responsible for the secretion of aldosterone. And what is the function of the aldosterone? Basically, we know that simply we just say what is the function of the aldosterone. We say that the aldosterone is responsible for the retention of the sodium in water molecules. Okay. But instead of that, in the better definition, we can say over here the aldosterone basically they work where? On the aldosterone receptors. And where is the presence of the aldosterone receptor? That is the ENaC channel, right? So epithelial sodium channel. Epithelial sodium channel. And where is this channel present? Basically, we will get the presence of this channel present where? Within the DCT, distal convoluted tubule, and the collecting duct of the nephron. Okay. So if we see a little detailed structure of this one, for example, I am considering. Okay. I am considering this is the DCT or collecting duct, whatever you can see over here. Now, what actually we will get over here? For example, this is the ENaC channel. This is the ENaC channel, right? Now, what aldosterone will do? It will activate this channel. As a result, we will get the retention of sodium and water molecules. So we will get over here sodium and water molecule or retention, and also along with that we will get also the excretion of the potassium and proton, rather you can say hydrogen ion. Okay. So this is the main function of the aldosterone. Now see the aldosterone that is activated whenever we will see for whatever the regions. If we see the activation of the RAS system, at that time the aldosterone that will be activated. Okay, under normal physiological circumstances. So this aldosterone that will be controlled by basically by the RAS system. The RAS system for, as you know, it's very simple thing, renin, angiotensin, aldosterone system. Okay. I'll go in detail later. Okay. First, let's know the basic things of each layer. And then the second layer, we got over here the zona fasciculata. Now see this zona fasciculata that is responsible for secretion of cortisol. So cortisol. Okay. Now see, at first from the hypothalamus there will be the releasing of CRH, corticotropic releasing hormone. Okay. At first, if I say from the basic, at first from the pituitary gland will get the releasing of anterior pituitary, the hypothalamus will get the releasing of CRH, and this CRH that will come and that will activate the anterior pituitary cells to release the ACTH, and this ACTH is having the receptors who are within the zona fasciculata. So what did I say up to now? That at first we will get the releasing of the CRH, or rather you can say the corticotrophin releasing hormone that will be released from the hypothalamus, and that will activate the anterior pituitary cells to release the ACTH. This ACTH is having the receptors who are within the zona fasciculata, and they will, after that will get the releasing of the cortisol. Okay. And what is the function of the cortisols over here? The cortisols that is responsible for, actually it is known as the stress hormone, right? Stress hormone. Now during stress, this hormone that will be released. Now basically, one of the function I am just mentioning over here, that is responsible for causing the gluconeogenesis. So gluconeogenesis will get whenever the cortisols that will be released under stress conditions. At that time the gluconeogenesis process will be there, and whenever we will get the gluconeogenesis, as a result we will get the within the blood the glucose level that will be elevated. As a result, sometimes you can get also the case of impaired glucose tolerance test. So sometimes you can get also the impaired glucose tolerance. Okay. Now we'll talk about the zona reticularis. Now the innermost layer of the adrenal cortex. What I am saying, the innermost layer of the adrenal cortex will get the zona reticularis, and this zona reticularis that is responsible for the secretion of sex steroids, right? Sex steroids. As you know, the testosterone, or rather you can say the androgen. Now they are responsible for giving the characteristic features of the secondary sexual characters. Okay, so near about 20 sexual characteristic features that is getting expressed by the secretion of these sex steroids. Okay, from the zona reticularis layers of the adrenal cortex. Secondary sexual characters. Okay, these are the functions. Now we will talk about the inner layers, inner layer of the adrenal gland. So what is the inner layer of the adrenal gland? That is nothing but the adrenal medulla. So if we talk about the adrenal medulla, see, for example, I am just showing this the adrenal medulla layer. So from the adrenal medulla, let's write it over here, adrenal medulla. So from here basically we will get the releasing of the three hormones. One is norepinephrine, one is epinephrine, another is dopamine, right? Now see, one question is frequently asked in the FMG exam, that which of the hormone is having the maximum concentrations under normal physiological circumstances within the blood. So if the question is asked under normal physiological circumstances, which of the following hormone is having the maximum concentration, then definitely we should say that epinephrine is having the more concentration with respect to the norepinephrine, near about 60% among these three. Okay, but if you get a pathological conditions, for example, if you get the development of the tumor within the adrenal medulla, that is nothing but the pheochromocytoma. So if we get the development of pheochromocytoma, the tumor within the adrenal medulla, at that time we will get the reverse case. In these cases we will get the norepinephrine, concentration of the norepinephrine that will be greater than the epinephrine. Okay, is the reverse case. Now see, okay, if we get the epinephrine or norepinephrine, whatever the hormones we are getting over here, just for diagnostic purpose, sometimes we need to know that what will be the metabolite, what will be the products after the metabolism of these hormones. What will be the products in the metabolism of these hormones? For especially if we talk about epinephrine and norepinephrine, whenever they will be completely metabolized, they will give the production of vanille mandelic acid. So vanille mandelic acid, that is the product of epinephrine and norepinephrine. Along with that, if we say for example for the dopamine, so whenever the dopamine that will be completely metabolized, we will get the product of, after metabolism, we will get the product of homovalenic acid. homovalenic acid. Okay, so these are the products. Now see one thing, that this epinephrine, norepinephrine and the dopamine, these hormones are having the same features, that they are made up of on the same kind of the amino acids. So the tyrosine amino acid, that is responsible for the formation of epinephrine, norepinephrine and I'm writing NE, okay, then it will be better for you to understand. Epinephrine, norepinephrine and the dopamine. Along with that, we also know that the tyrosines, that is also responsible for the formation of T3 and T4. That is also responsible for the formation of T3 and T4 hormone. Okay. Now see, that means in a nutshell we can say the tyrosine amino acid that is responsible for the production of the epinephrine, norepinephrine, dopamine. Along with that, it is also responsible for the formation of T3 and T4. That means the triiodothyronine and tetraiodothyronine. Okay. Now we'll talk about the disorders of these things. Okay. Now at first we'll talk about the primary hyperaldosteronisms. Then we'll go to the secondary hyperaldosteronisms. Okay. Let's talk about those things step by step. Wait on me. Okay. So at first, we will try to cover the primary hyperaldosteronisms. Okay, that means the overfunctions or overaction of the aldosterone. First thing, the primary hyperaldosteronism. Why we will get this type of thing? What are the etiologies? So basically, as far as the etiology is concerned, we will get the two types of the things over here. One is known as, if we get the bilateral adrenal hyperplasia, in this case we can get the hyperaldosteronisms or the hypersecretion of the aldosterone hormone. Along with that, if we get the tumors, for example, as I said you over here, okay, let's draw once again. For example, this is the first layer. The first layers of the adrenal cortex that is responsible for the secretion of the aldosterone hormone. Now, if we get, for whatever the reasons, if we get the development of the tumor within the first layer of the adrenal cortex, that means within the zona glomerulosa over here, okay, that is nothing but that is known as what? Cohn's syndrome. So in terms of the Cohn's syndrome, we will get the development of tumor within the zona glomerulosa. That is nothing but the first layer of the what? Adrenal cortex. That is nothing but the first layer of the adrenal cortex over here. Okay. Then what type of thing we'll get over here? And another case, before going through in detail for these things, I'll talk about another case for the secondary. So, for example, I'll continue these things, okay, don't worry, but right now I'll talk about the secondary hyperaldosteronisms, and I'll just start through a clinical case scenario. Okay. For example, there is an individual who is having the ascites and he has come to our OPD. So, whenever we are getting the presence of the ascites, try to understand, that means within the abdominal cavity or within the peritoneal cavity we are getting the accumulation of the fluid. That means the fluid within the blood, that will be less. So whenever the fluid within the blood, that will be less, definitely less amount of the blood, that will be where? That will go where? Within the kidney, that means within the nephron. As a result, we will get the less amount of the GFR, and whenever there will be less amount of the GFR, the different kinds of the sensors are present over here where? Within the nephron, that will stimulate for the releasing of the what? Aldosterone hormone, right? Now, okay, let's talk about this thing. So if you get the development of the ascites, in these cases we'll get the circulatory volume, mark my word, circulatory volume, that means the blood, that will be less, because ascites, most of the fluid that is getting accumulated over where? Within the abdominal cavity. Now for the circulatory purpose, the amount of the volume that will be less over here is from the basic things, we know it, right? And whenever the circulatory volume that will be less, try to understand the GFR, the glomerular filtration rate, that will be also less, because less amount of the blood is available, so less amount of the blood that will go where, within the nephrons, so the GFR that will be less. And whenever the GFR that will be less, the RAS system that will be activated, right? The renin, angiotensin, aldosterone system that will be activated. And whenever it will be activated, it will lead to the secretion of the what? Aldosterone. It will lead to the secretion of the aldosterone. Okay. And the different kinds of the conditions that is responsible for causing the GFR less, we can say in terms of the the nephrotic syndrome, or you can say for the congestive heart failure, or you can remember like the restrictive cardiomyopathy. Okay, these are the conditions. In these cases, we will get that less amount of the GFR within the nephrons. As a result, we will get the activation of the RAS system, and that will ultimately give the stimulus for where within the zona, within the zona glomerulosa, to release more amount of the what? Aldosterone. Okay. Now we'll talk about the clinical manifestations and the workup of these patients. Okay. At first we'll talk about the primary. Okay, so let's talk about the primary. What are the clinical manifestations we will get, and what are the workups and the diagnosis and treatment also. Okay. Now see, as I said, in terms of the primary hyperaldosteronism, I am writing hyperaldosteronism. For example, in this, okay, primary hyperaldosteronism. Now in these cases, I have already explained you before that in this, whenever the more amount of the aldosterone will be over here, see, whenever the more amount of the aldosterone that will be secreted, they will activate the ENaC, that means the epithelial sodium channels, where within the DCT or collecting duct. Okay. Now in these cases, try to understand, guys, that what did I say you, that the aldosterone hormone that is responsible for the retention of the sodium in water molecules by the activation of ENaC. So this is the nothing but the ENaC, epithelial sodium channels. As a result, we will get the sodium in water retention. Along with that, we will also get the excretion of the potassium and the proton. So whenever we are getting the retention of the sodium in water molecules, apparently that will lead to the what? Hypertension. That will lead to hypertension. Along with that, we will get the excretion of potassium and then the proton. So whenever we will get the excretion of the potassium and the proton, so for the more excretion of the potassium, that will lead to what? Hypokalemia. And we are getting also that the excretion of the proton, that will lead to what? Alkalosis. Okay, so ultimately we will get over here that hypokalemic alkalosis. So what did I say you up to now? That whenever the aldosterone that will be activated too much, this aldosterone that will cause the sodium and water retention. As a result, we will get the development of the hypertension. Along with that, this aldosterone that is also responsible for the excretion of proton and potassium ion, that will lead to the hypokalemic alkalosis. Hope it clear up to this much. Now the next thing is over here, what are the clinical manifestations we will get? So what are the clinical manifestations? So the first thing, in terms of the clinical manifestations, guys, we'll get the headache. So whenever we are talking in terms of the headache, for example, if we get in terms of the primary hyperaldosteronism, we are getting the development of the tumor, or it may be the bilateral adrenal hyperplasia in these cases. Okay, so there is an individual who is having headache. Of course, he is having the hypertension. For hypertension, he is using the drugs. For example, he has taken the three standard group of the antihypertensive drugs. He has already taken. So for example, he has taken over here AC inhibitors, or he has taken also the he has taken the AC inhibitor, he has taken the calcium channel blocker, and he has also taken the what? Thiazide, including thiazide. So he has taken all these drugs, three groups of the classical antihypertensive drugs. After that also we are getting the hypertension resistance. Hypertension resistance. After taking all these drugs, yet the hypertension that is not getting cured. Okay, what may be the reasons? The first thing is over here, if we get the development of the tumor within the zona glomerular layer, so that will be responsible for the secretion of the more amount of the aldosterone. So more amount of the aldosterone, that will cause the more amount of the sodium and the water retention. So that will leads to the hypertension. If you use the drug, yet it will be not able to cover the situations. That's why we will not get the patients fully cured. Okay, that's the one thing. Now another thing, for example, another cause, the most common cause, that he is taking the drug. Yet the hypertension is not getting cured. Another thing is maybe over here there is a non-compliance. Maybe the individual, they are not taking the medications on time, or he just skipping some medication. Okay, this is the most common cause. Apart from it, we will also get if we get the development of the bilateral adrenal hyperplasia, or if you get the tumor within the zona glomerular layer, that is nothing but the Cone syndrome. In these cases, we will get the secretion of the more amount of the more amount of the aldosterone, that will cause the retention of the more amount of the sodium and water molecules. Ultimately, we will get the development of the hypertension. That's why we will get the hypertension resistance. We are using the drugs because the secretion of the aldosterone, that is overcoming this drug, the action of this drugs. As a result, we will get the hypertension resistance. Another thing, if we just do the urinary analysis, in these cases I have already explained you that whenever the aldosterone that is acting more, in these cases we will get the excretion of the more amount of the potassium and hydrogen ion, or the rather we can say the proton. So in these cases the proton is going, the potassium is going. So whenever the potassium is going, that will lead to what? Hypokalemia. So we will get over here hypokalemic, and the protein is going, that will lead to what? Alkalosis. So ultimately we will get hypokalemic alkalosis. Okay. Now another important thing okay, another important aspect over here, sometimes that normally what do we know, that whenever the sodium and water retention is over here, definitely we are supposed to get for the edema, but in these cases we don't get the pedal edema. In terms of the primary hyperaldosteronism. What's the reason for it? This is one of the most important questions. So for example, okay, so whenever the aldosterone is acting more, so as a result we will get the retention of the sodium and water molecule more also, right? So whenever the water molecules is getting more within the circulations, definitely the preload, right, mark my word, the preload within the right atrium, that will be more, right? So whenever the preload that will be more within the right atrium, that will cause the dilation of the what? Right atrium. So in these cases we will get the dilation of the right atrium. Dilation of right atrium. So whenever we get the dilation of the right atrium, this right atrium that will be activated, and this right atrium that will release atrial natriuretic factors. So what is it? Atrial natriuretic factor. So basically what type of the thing we'll get over here. For example, whenever the aldosterone was acting over here, we got the sodium retention, for example 3+, and water retention, for example 2+. Okay. Now what it will do, this atrial natriuretic factors, it will cause the excretion of sodium, that means the salt, but it will be not able to excrete all amount of the salt. For example, out of the 3+, it is able to remove 2+, still some amount of the salt that will be left within the circulation. Okay, but whenever the atrial natriuretic factor is coming over here, that will be able to eliminate whatever the water molecules was retained, the same amount of the water molecules that will be excreted through the urine. So here we will get the water molecules will be not over there. What I am saying, try to understand. The aldosterone was acting over here. As a result, we got the sodium and the water retention, right? But as a result, we got the preload that was increased. So whenever the preload got increased, we got the the pressure within the right atrium, or the we can say that within the right atrium, that volume that was increased. As a result, we got the dilation of the right atrium. So whenever we got the dilation of the right atrium, that leads to the releasing of the atrial natriuretic factor. And this atrial natriuretic factor that is responsible for the excretion of the, especially what? Natriuretic means what? Natriuresis. So through the urine we will get the releasing of or excretion of the sodium. Along with that we will also get the excretion of the water molecules, because as we know that the sodium water molecules follows to the sodium molecules, right? So in these cases the water molecule is going out from the body. That's why whenever the water is absent, so there is no chance for the development of the edema. That's why in these cases we will not get the no pedal edema. No pedal edema. Hope it's clear for you. Okay. Now I'll talk about the workup. What are the diagnosis you can see. So as far as the workup is concerned, what type of thing we will get over here? So okay. Let's talk about workup. What type of thing we will get under workup? At first, the two important thing that the within the we can say over here that the sodium level within the blood and the potassium level. As I said, that whenever the ANF that will be released, some amount of the sodium or the salt will be still left here within the circulation. That's why we can say the sodium that will be normal within the circulation or slightly high. But what about the potassium? The potassium that will be severely decreased, because the potassium is getting excreted through the urine by the action of the aldosterone. Okay. Now another thing, just to check whether there is the presence of the tumor or not, or the hyperplasia or not. That's why we should go through what? Enhanced CT scan. By doing the CT scan, we can get the anatomical positions of the gland. Okay. We can find out easily that whether there is presence of any kind of the tumors, or if we get any kind of the hyperplasia or not. Okay, that's the thing. And the most important test over here, the most important test, okay, I should mark it clearly. That is